So let's dive into module number 6. This module covers the gastrointestinal system. So there will be some PowerPoints for me, but within this PowerPoint, I found some excellent videos online that I'm going to refer you to just to give you some more in-depth discussion on certain areas. The big thing to focus on is that abdominal pain occurs commonly, but there's certain things that you need to make sure that you know. So both you need to know what are the most common causes and the most common presenting symptoms of different types of abdominal pain. Familiarize yourself with the top differentials. This will help you determine the diagnosis. The physical exam will be focused on maneuvers. So think about things like rebound tenderness, left lower quadrant pain. Just think of your maneuvers for abdominal assessment. Just go back and review all of those. So ways that you can help identify gallbladder, appendicitis, diverticulitis. Go back and review those things. And you should also know what diagnostic studies to use for different types of abdominal pain. The next thing that you should be very comfortable with is knowing when to refer. These are examples of when you should refer on to either a specialist or the emergency room. Remember, these are things that are not going to be within a typical family practice clinician's wheelhouse. If you have a suspicion of a GI bleed, that is an emergent situation. Bowel obstruction, changes in vital signs, a patient that is jaundiced. If you have a patient that has a positive pregnancy test, so say a patient finds out that she's pregnant 5 minutes before she comes into your office and she's having severe abdominal pain, that is an emergent situation. If you see someone with severe localized pain, especially when it's unilateral, that is an emergent situation. If there is trauma and they're having abdominal pain, swelling, abdominal bruising, emergency room immediately. And if you have any indication of peritoneal irritation or infection, that is something that cannot be worked up in an office setting. There are different types of abdominal pain. Make sure that you know what to look for with appendicitis. So for instance, with that, you're thinking of the right lower quadrant pain, perhaps a fever, perhaps there's some nausea and vomiting, perhaps there's some constipation. Very rarely will this patient have diarrhea, but it's still a possibility. When you think of peptic ulcer disease, a perforated peptic ulcer, there would be an abrupt onset of severe abdominal pain. And then you have those peritoneal signs very rapidly. If you're concerned of low back pain, make sure that a ruptured aortic aneurysm is someplace in your differential for many of your patients as they get older. So just think of the different sources of abdominal pain. And one I didn't include on here is left lower quadrant abdominal pain. Remember, diverticulitis should be on your differential list. I've included an excellent video on gallbladder. Please download the PowerPoint and play this video. It's an excellent video. Diarrhea is something that patients will come to your office for quite frequently. Just because a patient says they have diarrhea doesn't mean that they clinically meet the criteria for diarrhea. So if a patient tells you they had one soft stool, that is not diarrhea. So diarrhea is an increase in stool frequency to more than 3 stools per day. And typically this is going to be a loose or liquid stool. Acute diarrhea is typically self-limiting. There's a lot of stomach viruses that will give people temporary issues. They could have eaten something that kind of irritated their stomach. Most of the time, diarrhea completely goes away on its own. If there's a concern of infectious diarrhea, like something like traveler's diarrhea or perhaps food poisoning, that may require additional testing. So you may need to have stool cultures completed on that patient. And that's something that you'd be able to order from your office. The physical exam would be complete history, complete physical. The physical needs to be appropriate to the complaint. And the history should definitely include things that could possibly be a cause for the diarrhea. So make sure you go over the travel history with the patient. See if anyone at home has been sick. Does the patient have fevers? Has the patient noticed blood in their stools? Assess the patient for patterns and potential triggers. This is where that good history taking comes into place. Look at their personal medical history. Perhaps this is a reoccurring problem and maybe you need to refer them on to GI. Look for red flags. Always know your red flags. So remember fever, severe abdominal pain, if they're dehydrated, if they're just passing bloody stools. Those are things that require a referral. Another area to look at is GERD. The most common symptom of GERD is heartburn or feelings of regurgitation. Less common symptoms I do have listed here. Some patients will complain of chest pain. Some people have hoarseness. Some people have a globus sensation. There are many disorders that can mimic heartburn, so you don't want to label a patient with heartburn too quickly. For instance, you do not want to miss a patient in the middle of an MI. You don't want to mislabel that as heartburn. One of the symptoms of GERD is that it will occur at least 2 days per week. Red flags, and the reason these are red flags is because you are concerned for a possible malignancy. So, abdominal pain that sets in after the age of 60 is a red flag. If you have a family history, a first degree relative with GI cancer, red flag. If there is an unexpected weight loss, that is concerning. If there's an appetite change, if the patient begins to have difficulty swallowing, if the stool becomes dark, if the stool becomes fatty, if you draw blood and now suddenly they have iron deficiency anemia, or if a patient has persistent vomiting. Those are reasons for you to dig deeper, consider additional testing, and referral. The management for GERD focuses on H2 and PPIs. Now, guidelines have changed, and this probably won't appear on your tests just because it's newer than the textbook. With PPIs, the current guidelines are you don't want to leave patients on PPIs longer than is necessary. So when the patient begins to feel better, you want to begin to taper off those PPIs. And I have a video for you guys about that in your course announcements. So please go back and review that video. GERD management doesn't just focus on medications. There are also things that the patient can do to decrease the frequency of GERD flare. Look at lifestyle. If the patient consumes high amount of caffeine, alcohol, if they're a smoker, if they're eating right before bed, those are all possible triggers of acid reflux. The patient should also avoid foods that are fried or spicy or chocolate, things that could potentially trigger the acid reflux for the patient. Some patients need to elevate the head of the bed. Other patients need to avoid NSAIDs. So maybe the patient's unable to take naproxen or ibuprofen. But these are things that you would go through. You get this from the history, and then you would teach the patient so that way the patient is empowered to help manage their condition. Another excellent video that I found online. Please take a few moments to review this video. It's really good. Another video I have, I feel like I'm the video lady on this lecture, about peptic ulcer disease. They do a great job of explaining these, so it's kind of one of those things where I don't feel like I need to reinvent the wheel if it's already out there and it's available for free. I want you guys to take advantage of these lectures and listen to those in addition to what's in your textbook. And finally, there is one on diverticulosis and diverticulitis. You will have to click the link to watch this video. Oh, hold on. Oh goodness, you're going to watch me do all of my security checks. So we're just going to close out of that one. Um, but I assure you, I am a human and I did enjoy this video. So as always, let me know if you have questions.